Can you hear me again? Good morning. I am Dr. Jose Marcia. Welcome to our DOH-PCP webinar. So it is about renal manifestation in pandemic and endemic. Before we start, may we offer a minute of silence to pray to our Lord. Let us pray for the recovery of the world. Pray for strength and courage to overcome this crisis and to offer our own personal prayers. We will now start the PCP proper. So PCP CME prepared two exciting lectures. They are crosstalk between an infectious disease and how they affect other systems, with emphasis in the kidneys and renal function. Today's topics are very timely because the discussion is about the ongoing battle, and the other is a potential emerging problem. These two lectures would be presented and a question and answer would follow. We will now proceed to the meat of the discussion. The objectives in the first lecture would be to review the pathophysiology, to discuss the development and management of renal manifestation in AKI with COVID patient, and what is the impact and treatment management of these patients. I am very honored that I will introduce to you two speakers. They are genuinely experts of their field. You can call them experts among experts. I would like to apologize in advance to the two speakers that I have intentionally shortened their CV. Believe me when I say their achievements, their researches, their current and past position are longer than their positions. So I would like to introduce to you Dr. Robert Tanchanco. He graduated from Ateneo de Manila University with double degree of BS Biology and AB Philosophy. He completed his medical studies at University UERMMC and completed his internship, his internal medicine residency, his adult nephrology and transplantation fellowship training program at UPPGH, and served as a clinical associate professor for 4 years. Then he had an international fellowship program. He completed it at the Cleveland Clinic in Ohio, USA. He obtained his master's degree in Business Administration Silver Medal at the Ateneo Graduate School of Business in Makati City, Philippines. Dr. Robert Tanchanco is a practicing nephrologist at the Medical City. He was our president at the PSN and currently my boss at the Ateneo Graduate School in Medicine. And without further ado, I would like to introduce again Dr. Robert Tanchanco for his lecture.
Thank you, Jose. Good morning, everyone. I hope everyone is healthy and safe. Let me just share my slides. Okay, can you see my slides? Okay, thank you, Dr. Dingdong Beruar, for extending the invitation. Dr. Alvin Loyola, head of the CME committee, Dr. Agnes Torrio Cruz, board region champion, and to our PCP president, Dr. Mario Panaligan, and also the immediate past president, who is also a past president of the PSN, Dr. Gina Nazareth, for this opportunity to share with you my thoughts and experience regarding renal involvement in COVID-19. I was tasked to speak on the pandemic disease, and this graph from the European Morbidity and Mortality Database clearly shows how the mortality rate from March to May far exceeded what was noted over the same months from 2016 to 2019. This excess mortality is due not just to COVID-19, but also to those other diseases that were not as well treated because of the diversion of resources to battle this pandemic. And this spike in mortality surely included many patients with kidney disease, either newly acquired or chronically present. So let me start by telling you a little bit about two patients that we saw in the medical city who fortunately survived their ordeal with COVID-19, but had to struggle through kidney failure, among other complications. The first is a 62-year-old man, diabetic and hypertensive, who presented with fever, cough, and sore throat. He was stable on admission, but at a certain point rapidly deteriorated and required intubation and proning. He required dialysis by the fifth day in the ICU and also underwent hemoperfusion for 3 sessions. He was extubated after 20 days. Dialysis was stopped after being on it for 3 weeks. He continued to recover slowly but surely and was discharged on the 53rd hospital day, feeling much better with a discharge creatinine of 1.07, and that improved to 0.8 1 month later. The second is a 58-year-old man, also diabetic, also hypertensive, who came in with progressive dyspnea and diarrhea. His deterioration was much faster, requiring intubation soon after admission, also underwent proning, also required vasopressors. His SAPS-2 score was higher at 52, but his initial serum creatinine was lower at 0.98. He also required renal replacement therapy. He also underwent hemoperfusion. He was able to tolerate extubation after 18 days, but his course of recovery was complicated by bacterial and fungal infection. He was re-intubated twice, eventually underwent tracheostomy. He had to be given vancomycin, polymyxin B, and he also had a stroke on the 30th hospital day with hemorrhagic conversion. But he was able to recover from all that and finally got to go home after 99 days in the hospital. He was able to stop dialysis after 2 months on it. After all he went through, his discharge creatinine was 6.32 milligram per deciliter. And happily, his creatinine has been going down. It's now at 4.25 milligram per deciliter. So we see in those two cases that the kidneys can be rather severely affected in COVID-19. In general, renal involvement can be seen in 2 ways. First, patients with good kidney function can develop AKI when they contract COVID-19. And this seems to occur in about 9% of all COVID cases. But when it does occur, their risk of dying is higher. Second, COVID-19 can affect patients who already have chronic kidney disease. And whether they are dialysis or transplant patients, they tend to have more severe manifestations and higher mortality. Also, we have noted that dialysis and transplant services are very much disrupted for all patients, whether or not they have COVID-19. So my outline for my talk will be as follows. First, to review the pathophysiology of COVID-19 infection and how it affects the renal system. Second, to discuss the incidence of AKI and its prevention and management for patients with COVID. Third, to discuss the impact of COVID-19 on dialysis and transplant patients. And finally, to present some local data on COVID-19 and renal involvement. So for the pathophysiology, let me begin with ACE2, the enzyme that has been identified as SARS-CoV-2's preferred gate of entry into the cells of the human body. As a virus, SARS-CoV-2's goal is to propagate itself in whatever host cell becomes available. Its key, which are the glycoprotein spikes on its surface that make it look like a crown, fits into its corresponding lock, the ACE2 enzyme, allowing the virus to enter into the cell. We know from basic physiology that the angiotensin converting enzyme, or ACE, catalyzes the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 then induces vasoconstriction and sodium and water retention. ACE2 is the counter-regulator of ACE, producing angiotensin 1 to 7, which binds with the mast receptor and induces vasodilation and natriuresis. We can think then of ACE and ACE2 as much like yin and yang, balancing each other's effects. So where do we find most of ACE and ACE2 in the body? Well, just a bit of historical trivia. In this review from 37 years ago, you will note in the diagram that ACE used to be called the pulmonary converting enzyme. And we know that a good amount of ACE, and therefore ACE2, are located in the type 2 alveolar cells in the lungs. Aside from the type 2 alveolar cells, high ACE2 RNA expression has also been noted in the oral and nasopharyngeal mucosa, in the upper esophagus, the absorptive enterocytes of the ileum and the colon, myocardial cells, cholangiocytes, the brain, the kidney proximal tubule cells and podocytes, and bladder urothelial cells. Hence, we note the corresponding clinical manifestations of COVID-19 reported in the literature: respiratory symptoms, anosmia, diarrhea, cardiac injury, elevated liver enzymes, encephalopathy and stroke, and acute kidney injury. So is there proof of direct kidney infection by SARS-CoV-2? The answer appears to be yes, as shown in a report of 26 autopsies conducted in China that looked closely at the renal findings. All patients had RT-PCR proven COVID-19 and died due to respiratory failure with multi-organ dysfunction syndrome. The average age was 69 years, with 19 males and 7 females, and 9 showing clinical signs of kidney injury with an elevated creatinine or proteinuria. And the main findings were as follows. First, acute tubular injury, mostly involving the proximal tubules, where most reabsorption of most everything takes place, and the podocytes, leading to foot process effacement. Hence, we see clinically a rise in creatinine, proteinuria, and hematuria. Second, RBC aggregation in the peritubular capillaries with microvascular obstruction, but without platelets and fibrin deposition. This finding is consistent with a low flow state and prolonged hypotension, and it should be taken as a cautionary reminder not to push our patients too much into a negative fluid balance state. We employ a conservative fluid strategy, but we need to strike that fine fluid balance, the point where it is dry enough for the lungs, but still wet enough for the kidneys and for hemodynamic circulation. Finding this fine balance is a constant challenge for the nephrologist, the pulmonologist, and the intensivist, and requires a continuous multidisciplinary conversation. Third, coronavirus particles were seen by electron microscopy, mostly in the proximal tubules, with some noted in the podocytes. These particles were identified as SARS-CoV-2 by nuclear protein detection. So we know that SARS-CoV-2 directly infects renal tissue. The podocyte involvement would be expected to lead to glomerulopathy, presenting with proteinuria. And a collapsing type of focal segmental glomerulosclerosis was indeed reported to occur in the 63-year-old male, African-American, hypertensive, with COVID-19, who developed non-oliguric AKI with nephrotic range proteinuria of 5 grams per day and a peak creatinine of 8.4 milligram per deciliter. In this electron micrograph, you can see the asterisk marking a cytoplasmic vacuole within the podocyte with spherical particles within, which the authors interpreted as being the coronavirus particles. This higher magnification demonstrates the spherical structures more clearly, measuring 50 to 100 nanometers, which matches the dimensions of SARS-CoV-2, as seen in this example from the CDC files. SARS-CoV-2 was localized in the apical brush borders of the proximal tubules and the podocytes, the very sites where most ACE2 is located within the kidneys. These slides show a comparison between a non-COVID and the COVID patient, and you will notice a wider spread and more intense staining for ACE2 in the proximal tubules of the COVID patients, which the authors interpret as showing upregulation of ACE2 in these patients who died. So since SARS-CoV-2 enters cells by fusing with ACE2, one therapeutic possibility that has been suggested is to infuse patients with soluble human recombinant ACE2. If SARS-CoV-2 binds with these soluble ACE2 in the serum, less SARS-CoV-2 will bind with the membrane-bound ACE2 that will translocate them into the cells. So there is in fact a registered trial being conducted in Germany that will look at this therapeutic option. But we will need to wait until after November 2020 for the results, if any, to be reported. The involvement of ACE2 brings up two clinically important scenarios. The first has to do with the use of RAS inhibitors, the ACE inhibitors, and the ARBs, and the second with hypokalemia. First, the RAS inhibitors. It has been shown in animal studies that RAS inhibition leads to ACE2 upregulation. So it was said RAS inhibitors should be stopped to help prevent viral uptake and lung injury. However, stopping RAS inhibitors may in fact worsen lung injury. When SARS-CoV-2 downregulates ACE2, ACE activity is unopposed, leading to more angiotensin II-induced lung injury. RAS inhibitors, by damping ACE and angiotensin II activity, would actually protect against lung injury. Hence, stopping ACE inhibitors and ARBs denies the patient the cardiovascular benefits of RAS blockade and may also worsen acute lung injury. So the message at this time, do not stop the RAS inhibitors. The second clinical issue with ACE2 downregulation is hypokalemia. The unopposed angiotensin II activity leads to increased urinary potassium excretion. In this report from Wenzhou, China, of 175 COVID patients, 55% had hypokalemia, of which almost half was severe. And severe hypokalemia was more commonly seen among those with more severe disease, with lymphopenia, elevated CRP, and elevated LDH, and as expected among those with EKG abnormalities. This is important to anticipate and to manage, as hypokalemia can worsen lung function and also predispose to QT prolongation and arrhythmias. Kidney injury may also be caused by complement activation, the defense mechanism that can lead to an exaggerated inflammatory response as well as clotting issues. Viral invasion leads to complement activation via the lectin pathway, then the classical pathway. Then with the C3b deposition, the alternative pathway is activated as well, leading to cleavage of C5 to C5a and C5b. C5b then recruits monocytes, macrophages, and neutrophils, while C5b forms the membrane attack complex, leading to the release of interleukin-8 and the recruitment, adhesion, and migration of macrophages and neutrophils across the endothelium, leading to release of proteases, cytokines, and reactive oxygen species that cause inflammation, subendothelial matrix disruption, and remodeling. Aside from inflammation, further vascular injury and excessive clot formation are also induced by the release of P-selectin and von Willebrand factor multimers and shedding of thrombomodulin and procoagulant microparticles. This all leads to the extensive clotting issues seen in COVID-19 patients. So we see that there are multiple causes of AKI in COVID due to both direct injury from viral invasion of tubular cells and podocytes, as well as indirect injury from sepsis, reduced ECF volume, high PEEP, nephrotoxin exposure, organ crosstalk, and cytokine storm. So how commonly seen is AKI in COVID-19? In this review from the International Society of Nephrology, the incidence of AKI varied from 0.5 to 29%. And of course, the incidence is higher in the ICU setting. The need for renal replacement therapy is in the range of 0.8 to 17%. From a more recent systematic review with almost 7,000 COVID patients, mostly from China, the mean incidence of AKI is around 9% of hospitalized patients. So from that review, we can see that the patients admitted in New York were very badly hit. with an incidence of AKI of 37% and the mortality rate of at least 35%. And in the time period covered by this review, the excess mortality in New York City was more than 600% above expected. What is notable here is that in 52% of cases, AKI was diagnosed around the time of initiation of mechanical ventilation. And the other very notable finding in this study is that the mortality rate increased as the severity of AKI increased. And the same pattern is consistently seen in other reports. The risk factors for development of AKI included, not surprisingly, older age, diabetes, hypertension, cardiovascular disease, the need for ventilation, and vasopressor use. The preventive measures, which are also the treatment measures for AKI, include sepsis management with early goal-directed therapy, lung protective ventilation, conservative fluid management with close monitoring of fluid status using functional hemodynamic monitoring, the preferred use of balanced crystalloids for resuscitation, the use of norepinephrine as the preferred first-line vasopressor, and of course, avoidance of nephrotoxins. We also need to adjust all drug dosages as needed based on the estimated GFR and if they are on dialysis. Here is a table of some drugs commonly used in our COVID patients. And just a caution, it was hard to find such a reference. And so I derived this table from a manuscript from Brazil, written in Portuguese. I just hope Google correctly translated the words in the table, like semi-juste as no adjustment, now reportado as not reported, now recomendado as not reported, not recommended or avoid, and now dializado as not dialyzed. The indications for renal replacement therapy are the same as with other severely ill ICU patients with sepsis, though it is important to emphasize that it is better to initiate renal support earlier rather than later, and that if renal replacement therapy is initiated only once the absolute indications have presented themselves, it is generally too late. For patients who develop cytokine storm syndrome, another treatment that is considered is hemoperfusion. This modality is based on the cytokine peak concentration hypothesis, where the surge of cytokines in the system is said to breach a toxic threshold, and hemadsorption helps restore the balance by the non-specific removal of the peaks of the circulating pro-inflammatory and anti-inflammatory cytokines, with the intended result of lessening the severe immune system derangement and improving the immunological responsiveness of the patient. Cytokines cannot be removed by dialysis or CRRT, as the substances are generally too large to fit through the pores of the dialyzer membrane, but larger molecules are removable by adsorption. And I'm looking forward to Dr. Danilan's further inputs later on this treatment modality. Now let's move to the other scenario where we see renal involvement in COVID, when it affects patients who already have CKD. And for this, I'll just focus on two populations, dialysis and transplant patients. This report from Spain of 26 kidney transplant, 23 hemodialysis, and 2 peritoneal dialysis patients with COVID shows that the clinical presentation is the same, dominated by fever and respiratory symptoms, though with a high proportion presenting with GI symptoms and myalgia. The incidence of ARDS at 39% and death at 26% is also notably very high among dialysis and transplant patients. Further reports on dialysis patients show the same pattern. Among 643 hemodialysis patients in Italy, a higher risk of ARDS and death was noted among those who needed to be admitted. And among 36 hemodialysis patients in Spain, a higher risk of death and mortality was associated with a longer time on dialysis and a high LDH level and lymphopenia. With regard to transplant patients who are maintained on immunosuppressive drugs to prevent graft rejection, as expected, we see a more severe manifestation of COVID, especially in the older and diabetic patients, and a higher risk of disease progression and mortality that compels the team to withdraw immunosuppression in severe cases. COVID-19 has disrupted dialysis and transplant care so significantly that the Philippine Society of Nephrology was compelled to issue guidelines on how to prevent, control, and manage COVID infection in hemodialysis facilities. And also, in cooperation with the Philippine Society of Transplant Surgeons, issued their unified interim guidelines for kidney transplantation during this pandemic. So like PCP under the helm of Dr. Nazareth and now Dr. Panaligan, PSN has been busy coordinating with DOH and other stakeholders. And I'd like to tip my hat to our President, Dr. Elizabeth Roasa, and Vice President, Dr. Elizabeth Montemayor, their board, and all the PSN members who stepped up when they were needed and for their dedication to their duty. So perhaps we can go over some further details of those guidelines in the Q&A later, if we have time. But at this point, let me proceed and present to you some local data on renal involvement in COVID-19. And for this, I will be presenting to you some data from my place of practice, the Medical City in Pasig, which by the end of June had already admitted a total of 384 COVID positive patients. Also, there is an ongoing multi-center study by the Philippine Society of Nephrology, spearheaded by Dr. Vimar Luz and Dr. Arlene Afaga, regarding the experience of nephrology services with COVID-19 patients referred to them. For the Medical City data, I'd like to acknowledge the help of the following: Dr. Elizabeth Sebastian and our nephrology fellows, who even as we speak continue to input data daily. The online data collection system that Dr. Sebastian initiated will be used by the PSN for its multi-center study. Dr. Onya Nubaldo, the one with the orange top, who shared their ICU data, and Dr. Sibela Bad for sharing some aggregate data. So as of July 3, our renal service has seen 49 RT-PCR positive COVID patients with a mean age of 64, range of 25 to 94 years. 63% are male, 74% are hypertensive, and 49% are diabetic. And the population is rather peculiar, with many CKD patients at 39%. More than half presented with fever, dyspnea, and cough, and only 12% with diarrhea. Mild hypokalemia was noted in only 6%, or 3 patients. The mortality rate among all patients seen was 44.9%, though 6 patients are still admitted at this time. We had many COVID positive dialysis patients who needed to be admitted just to be able to continue dialysis until they were RT-PCR negative. So we also looked separately at those patients without pre-existing ESRD and who fulfilled the KDIGO criteria for AKI. And for that, I will present data current as of May 17, at which time there had been 255 RT-PCR positive COVID patients admitted, and of which 26 had AKI. So in our institution, the incidence of AKI is 10.2% compared to 8.9% in the systematic review. And the need for CRRT was noted in 7.1%. Among those who developed AKI, 35% had cardiovascular disease, 31% had CKD, 58% had diabetes, and 65% had hypertension. 31 of our COVID patients were admitted to the ICU, and of these, 58.1% developed AKI, compared to 3.8% in the wards. And among our ICU patients, the mean SAPS-2 score was 51. The mean PF ratio on ICU admission was 164. 94% required mechanical ventilation. Proning was performed in 42%, and vasopressors used in 54.8%. The overall mortality rate in our center is currently at 14%, but among those who developed AKI, the mortality is 65.4%. So here and elsewhere, the mortality rate is very high once a COVID patient requires ICU admission, but it becomes even higher when advanced respiratory support and renal replacement therapy become necessary. We see the same pattern in our 31 patients and the 52 patients in Wuhan reported, and in the 5,139 patients in the UK ICU database. Clearly, we need to do what we can to prevent patients from reaching the point where they need respiratory and renal support. So that's the preliminary data from Medical City. But the PSN intends to collate the collective experience of several centers in a retrospective cohort study on COVID-19 patients referred to the nephrology services. So for that, I'd like to share with you the pre-study survey findings for which 15 institutions responded. And through self-reporting, these institutions have seen 1,712 COVID positive patients, with 509 or 29.7% referred to their nephrology services. 60% are private hospitals, and CRRT was used in almost half, while hemoperfusion has been used in 2/3 of the institutions. So in summary, I'd just like to recap the things that I discussed. First, COVID-19 affects the kidneys both directly and indirectly. Second, AKI is an independent risk factor of mortality in COVID-19. Third, the severity and mortality risk of COVID-19 is higher among dialysis and kidney transplant patients. And fourth, local data is currently being gathered regarding COVID-19 patients seen by the nephrology services. And at this point, I end my presentation. Thank you for your attention.
Thank you, Dr. Robert Tanchanco. Before, uh, again, Dr. Obet was able to discuss the COVID infection in relation to the renal function. He presented the epidemiology, the pathophysiology, renal manifestation, the risk factors, treatment and management. He was able to show that there were next researches for the COVID-19 infection. Before we proceed to the next speaker, I just would like to give some instruction. Q&A will be Q&A will be after the two lectures. You can write the questions in the Q&A box in the Zoom or comment box in the live presentation in Facebook Live. Then we will read the questions later. We are now going to the next lecture. So for our next lecturer, I am very honored to present the next lecturer. She is Dr. Dangilan. She received her medical degree from the University of the Philippines, and she took her medical internship and residency in internal medicine at the Philippine General Hospital, UPPGH, and further studies in adult nephrology fellowship training program in Addenbrooke Hospital in Cambridge, United Kingdom. She received a diploma for Public Management Development Program Senior Executive Class from the Development Academy of the Philippines, finishing as class valedictorian among scholars from various government agencies. Dr. Romina Dangilan again holds a number of key positions in the National Kidney and Transplant Institute. It is the largest tertiary referral center for kidney disease and transplantation in the Philippines, including Deputy Executive Director for Education, Training, and Research Services. She heads several clinical trials and research unit and heads the Hemodialysis Center. But behind these achievements, behind these researches, Dr. Dangilan have produced one of the most numerous nephrologists in the Philippines, following her footsteps. Again, I am honored to introduce to you Dr. Romina Dangilan to present leptospirosis, and kidney disease.
Do we put it to slideshow? Slideshow. Slideshow. Okay. Okay. I'd like to thank the Philippine College of Physicians for asking me to give this talk and for me to share with you the experience of the National Kidney and Transplant Institute on leptospirosis, centering on leptospirosis and the kidneys. As we all know, leptospirosis is caused by the pathogenic species of Leptospira, commonly L. interrogans and icterohemorrhagica, causing the severest form of the disease. It results upon exposure of mucous membranes to the urine of infected animals, usually rats in our setting, commonly during floods, typhoons, and even just monsoon rains, in settings of poor sanitation or from occupational exposure. People working in sewerage or in marketplaces where there may not be the best of sanitation. It manifests with a wide range of symptoms from a mild flu-like illness to more severe complications such as jaundice, meningitis, renal dysfunction, and hemorrhage. Here's the epidemiology of the disease. It's the most common zoonotic disease worldwide, involving at least 1 million patients annually. And here I showed to you data from the Philippines. This is from the Department of Health. It shows to you the experience in 2019. The yellow bars showing the number of patients that are afflicted with the disease as reported by all the hospitals. This is from January to October. In 2019, there were 2,696 patients, a 45% reduction from the previous year when we had 4,866 patients in the whole country. If you look at the graph, the red line represents an epidemic proportion, and the blue line represents alert threshold. So you can see that towards the middle to third quarter of the year is when we see an upsurge in the patients coinciding with our rainy season. So we start to see it about June, July, August, where usually it starts to peak in our hospitals. So in this data from the Department of Health, there's been a decrease in the incidence in all regions last year, except for regions 5 and ATCAR. And I wanted to show to you the highest incidence among hospitals in NCR. San Lazaro Hospital, where all the patients with infections go, reported 166 patients. East Avenue Medical Center, our neighbor, with 219 patients. And here at the NKTI, we had the most number of patients at 249. This graph here shows to you the cases in the region of NCR. And again, showing that it usually peaks at the time of the rainy season. How do we get it? There is urine shedding of the organisms from infected animals, and this is the most important source. And then there is contact with the organism by humans, and this results in the infection as we know it. There is rapid access to the bloodstream through lymphatics, resulting in leptospiremia and spread to all organs, particularly the liver and the kidney. So usually patients will report wounds or skin breaks, or they may enter through the eyes, the ears of patients who have to swim in floods, especially children who may be swimming in these dirty waters. The incubation period is about 5 to 14 days. And in fact, at the NKTI, we usually really mark it. When there's a heavy rain with floods, we say, okay, let's count 2 weeks, and then we will see the surge of patients. However, recently, it's been found that patients can sometimes already manifest with the disease from as early as 72 hours and to as late as even 1 month post-exposure. So we really need a heightened sense of awareness of this disease, especially among our doctors who stay at the emergency room. The usual signs and symptoms are fever, usually high grade with rigors. Patients will have headache, retroorbital pain, and photophobia. Muscle pains are very prominent, localized to the calf and lumbar area. There is conjunctival suffusion, again, maybe very pathognomonic of this disease. Patients can also present with dry cough, nausea and vomiting, which may reflect the presence already of renal failure and diarrhea. In its most severe form, we have Weil's disease, and this is manifested by icteria or jaundice, renal failure with oliguria, hemorrhagic features, and even sepsis or septic shock. Let's look at the demographics. And again, here is data from the DOH, and it's a disease mostly afflicted by males, as shown here. In about 85% of patients, median age is about 31 years, but you see the peak in number of patients belonging to the age group of 20 to 24 years. So we see here a young population, usually without many comorbids, which is good in that the patients have the capacity for recovery completely from this very devastating disease, even if they have very severe lung failure or kidney failure or liver failure. How do we diagnose the disease? Here's a picture showing the MAT, a dark field microscopy of leptospiral from the microscopic agglutination test. Screening tests can use ELISA, IgM, and IgG. They are rapid tests already now. PCR can also be done. And confirmatory tests could be, again, using MAT or MAT, a single titer of MAT of more than equal to 1:200, or a fourfold rise in serum between the first and fourth week of illness are confirmatory of this disease. It's also possible to do DNA PCR and a culture from body fluids or tissues. In NKTI, we use IgM and IgG. And if patients come in who are negative for IgM, then we repeat the test after a week. And usually we will see that the IgM will turn positive already. Now, all our specimens are also sent to the RITM for them to do MAT, and they also do identification of the serovars. What is the pathology of this disease? The key finding is capillary vasculitis. And in fact, in all organs involved, you will see vasculitis in them. The leptospiral toxins break down endothelial cell membranes of capillaries in all the organs that it affects. There is then resulting endothelial edema, necrosis, and lymphocytic infiltration. And this will all lead to a loss of RBC. There is extravasation of fluid, causing secondary tissue injury. And in its most severe form, it will cause ischemia to the tissues and even necrosis. So this is a very important pathophysiological mechanism, that it is more of a vasculitis and severe inflammation that ensues. There are two clinical syndromes that are common. We have the anicteric, which represents mild to flu-like illness, and the icteric or Weil's disease, which is a severe illness with multi-organ involvement and even failure. There are two distinct phases of illness. We have the septicemic or acute phase, which usually lasts from 5 to 7 days, followed by 1 to 3 days of improvement. Patient becomes a febrile. And then we have patients entering the immune or delayed phase, wherein fever returns. Patients may then get myalgia, headache, which may be part of a septic meningitis, and all other organ failures will come. Now, if patients will present with the icteric clinical syndrome, it is very hard already to differentiate between these two phases of illness. They will all appear all together already at the single time when the patients present to you at the emergency room. Let's talk a little about lepto and the kidneys. The kidney is the preferential colonization site where leptospira accumulates during systemic infection, primarily in the interstitium and in renal tubule epithelial cells. This is a very nice picture. It's a scanning electron micrograph where you can see these spirochetes. In acute kidney injury or AKI, the main histological findings are acute tubulointerstitial nephritis, as the leptospira do accumulate in these areas. And of course, it can also lead to acute tubular necrosis, since the organisms are highly present in those two parts of the kidney. The proximal tubule dysfunction and various electrolyte abnormalities are therefore very common manifestations of this disease. An NKTI study done just this year showed 751 patients with lepto and renal involvement, as defined by a creatinine of more than 3 and urine output less than 400 cc per day. And you can see here the marked presence of tubular dysfunction manifested by hyponatremia in 72%, hypocalcemia in 45% of patients, hypokalemia in 40%, hypomagnesemia in 15% of patients, and hyperphosphatemia in about 5%. So you can see here that it's very important for us to measure these various electrolyte in our patients, because a lot of them will need correction. In this same study, Dr. Capuchon also showed that among these electrolytes, it's the calcium and the potassium that take longer to recover. So that even when the patients are discharged, they will usually still be on some degree of calcium and potassium supplements. And this is something that we will need to check in the patients when they come back for follow-up. So it's a very extensive damage to the tubules, and it's something that takes longer to recover. So even whilst the patient is able to maintain a urine output at that time and is off dialysis, these electrolyte abnormalities still persist, and they still need to be corrected. The endothelial cell is injured in leptospirosis, and they say that it is the adherence junctions, and alterations of the cell membranes occur, leading to altered permeability. The immunohistochemical exams and autopsies confirm a primary lesion of the proximal convoluted tubules. There is a decrease of the sodium-hydrogen exchanger and the aquaporin 1 and 2 and your sodium-potassium ATPase. So all of these that require ATP will be affected by this disease. Sodium and water transport are particularly affected, with increased distal potassium excretion and consequent hypokalemia and polyuria. Many of these patients will actually present with non-oliguric renal failure, so that they're azotemic and yet they're putting out 1 to 2 liters of urine. So we have to know that because the pathology of the kidney will present with polyuria, it should not leave us to think that the kidneys are not extensively involved, so that BUN creatinines have to be checked in order to determine if the patient is azotemic, because it will have to be corrected either by dialysis or other treatments. Vascular endothelial cadherin has been shown to be part of the slit diaphragm protein complex of the glomerular podocytes. And it is seen here in these slides that VE cadherin in immunohistochemical expression in the glomerular capillaries was diminished and even focally absent. So these proteins are very important. They are responsible for maintaining structure between cells, and they lose their expression and are absent. And this may be the pathophysiologic mechanism for why you have an increase in cellular permeability in leptospirosis. On the left-hand side, we see a normal expression of V cadherin in the brown staining here in normal human glomerular capillaries, whereas on the right, you can see that V cadherin expression is diminished and even absent in focal areas of the glomerular capillaries in human leptospirosis. The glomeruli themselves show few alterations, usually manifested only by areas of foot process fusion, a focal swelling of the basal membrane and endothelial cells. The injury caused by leptospira outer membrane protein components involves innate immunity toll-like receptor pathways. Now, what are these toll-like receptor pathways? So they are responsible for inflammation. So that if you do not have these receptor pathways intact, it will allow marked inflammation to ensue. Okay, so it's very important for us to know that these receptor pathways are affected, and this may be responsible for the continued inflammation that permeates this disease. There is also activation of complement and immune cascades in the kidney, and therefore we are not surprised that some of these patients in its most severe form can go into DIC and sepsis and septic shock. So all of this, because of proteins present in the leptospiral outer membrane, result in a continued inflammation of the kidneys and even other organs that are affected. It can induce activation of TGF-beta as well, leading to accumulation of extracellular matrix. So I am sort of setting the tone for what may occur in patients in whom they are unable to fully recover from this disease. They become carriers of leptospirosis, and you can see from these pathophysiological mechanisms how it can result in a chronicity of destruction in the kidney, even if patients may have recovered from the acute disease. If the host survives the acute infection, septicemia and multiplication of leptospires will persist until the development of immunoglobulins, followed by a rapid immune clearance. The systemic immune response may eliminate the organism from the body, but it may also lead to a symptomatic inflammatory reaction that can produce secondary end organ injury, so-called the cytokine storm. Dr. Obet Tanchanko was able to present that in the COVID setting, where you have an exuberant inflammatory response to the disease, which initially may be protective because we do want stimulation of our immune response to control the infection. But because of the affectation of these toll-like receptors, sometimes the inflammation is not turned off, and it becomes a very bad thing for inflammation to be continuous and not to be controlled. And this, again, is another pathophysiology that will result in continuous damage, which will lead to continuous organ destruction if we are unable to control this so-called cytokine storm. And we'll talk about that a little more later. Leptospirosis then can lead to chronic kidney disease. So whereas before, we used to think that it presents only with acute kidney injury in quite a young population without comorbidities, so that the patient has the capacity to recover completely from end organ damage. We now know there has been increasing interest in research into factors in certain infectious diseases that may lead to chronic end organ damage. And this has been found in patients in various tropical countries, wherein it is commonly seen in rice or sugar plantation workers who present with CKD. And when you do an ultrasound, it will already show perhaps small kidneys, and this will be then labeled as CKD unidentified. So there is a huge interest in this area of a disease. When a leptokidney infection progresses, it may result in extracellular matrix accumulation. Remember the previous slide, which shows stimulation of TGF-beta. And this may be progressive and lead to chronic kidney disease. Leptospiral infection may be, in fact, a cause of primary kidney disease, AKI, or be a CKD susceptibility factor when kidney injury persists. And how did people know that? So they looked at these patients as farmers with CKD unidentified, and they checked for leptospiral antibodies. And they found that they had a lot of antibodies. And some of these patients may even still be presenting with urine with leptospiral identified, so that there is a permeation of leptospira in these patients, and they are now connecting it or associating with it with the development of chronic kidney disease. If we look here at the top part of this diagram, we see what we usually know: leptospiral infection inducing acute AKI. It is managed appropriately with antibiotics, hydration, and then there is a cure. However, if it's not treated properly, as many patients may not reach the hospital, antibiotics are not given, and AKI becomes more of chronic, and it may then lead to CKD and even ESRD. If you look at the lower part of the diagram, CKD may develop in an asymptomatic population where the carrier status of leptospira persists in the kidney, contributing to the progression of kidney disease. So you have a subclinical infection, the patient never goes to a doctor, never is treated. So you have colonization of the kidney with leptospira and continued inflammation even in asymptomatic patients, and it may lead to chronicity. And there has to be a second impact, maybe heat stress or dehydration in these farmers, and both of these can lead to a CKD continuum and even end-stage renal disease. Let's go to treatment and prophylaxis. We always say that leptospirosis is a severe disease. It can lead to dire consequences and even death, but it's a disease that can be prevented if the patient has proper prophylaxis. That is why it's so important to educate patients, educate our countrymen so that they know when prophylaxis is required. For mild leptospirosis, you can give doxycycline and amoxicillin. For pregnant patients and children, they can also have erythromycin. For severe lepto, however, you have to give Penji IV and even third-generation cephalosporins. And here is just a slide from the PISMID showing giving of prophylaxis depending on the risk category. Now I want to delve into the NKTI experience, and I want to show to you the journey that we have taken in order to show to you what or how we treat leptospirosis now at the Institute. And this is a picture showing to you just last year with increase in the number of leptospirosis patients that came our way requiring dialysis, that we had to convert our gym, our basketball court into a ward just for our leptospirosis patients. This gym can handle about 50 patients and with a single disease. The incidence of leptospirosis in NKTI is shown here across the years. As you can see, we had some peaks in 2012 where we had 150 patients, but in 2018 was the worst when we had about 450 patients coming in with just this single disease. In 2019, that was half. And I hope it was because there was better prophylaxis that was given and patients were more educated about how to prevent this illness. It's very important that when you get an outbreak such as this, where you're admitting 20 patients a day with severe disease requiring dialysis, that you need to have a lepto crisis management committee or a huge group of people to take a multidisciplinary approach to ensure that all these patients are handled properly. And this just shows to you a core group of nephrologists, internal med, because we need our pulmonary, our infectious disease colleagues. We also need our hematologists because of the coagulation disorders that occur. We need our surgeons to put access for dialysis. We need our social service to support the patients, since most of these patients will come from financially disadvantaged populations. We need our nurses, our ER physicians, and personnel. But these are just the core. We need more people. We need people in our warehouse, in our financing, in our pharmacy to help us be sure that we have enough medications and support supplies to handle all of these patients. How did we manage this outbreak? First, we needed to have an immediate diagnosis at the ER, a high index of suspicion for these patients. We need to know how to medically manage these patients very quickly, since they can immediately or very rapidly deteriorate, require intubation and other management. We also need to give them timely dialysis. And therefore, we had algorithms constructed for these to aid our physicians in the very quick management and identification of high-risk patients. And these were algorithms developed by our infectious disease, pulmonary, and our nephrologists. On the left side, we have the treatment for leptospirosis with patients with a particular clinical presentation. These are all the laboratories that we must do. And the initial management, it's very important that we hydrate the patients adequately while we wait for our lab results, and then give them the antibiotics that are required. We then developed an algorithm for dialysis therapy so that if the patients require dialysis, you see that on the orange box on the left side, then we determine if the patients fulfill any of the criteria for pulse therapy, because we immunosuppress these patients, because we are looking at the immunological pathophysiology of this disease. If yes, then we put the patients on hemodialysis, and if they do not have these severe criteria, then we put them on peritoneal dialysis. I want to show to you the criteria for pulse therapy, and any one of these may be present, and it will already signify that we will pulse the patient. A platelet count is in 100,000, patients who are hypotensive, requiring inotropes. They have lung infiltrates on chest x-ray, because this might be indicative of pulmonary hemorrhage, which is the worst complication that patients die of, and prolonged bleeding counts. Then we give them pulse immunosuppression, which consists of methylprednisolone, 250 milligrams IV after hemodialysis, daily for 3 days, followed by cyclophosphamide 1 gram as a single dose, or in case the patients already develop hemoptysis, we can give this straight away. At this point, if the patient needs pulse, we will shift them to ceftriaxone instead of Pen-G, and of course, we will give them anti-ulcer agents. I also wanted to show here that even the patients put on peritoneal dialysis who don't have those severe criteria will be given hydrocortisone 100 milligrams IV for a few days, to show to you that even if, as long as you will require dialysis, this is a severe type of illness that requires aggressive management. We need to produce or provide timely dialysis. And here in that gym, I showed you our picture of the gym. We have here installation of 5 hemodialysis machines with portable reverse osmosis for water treatment right there for all the patients that will require dialysis. And we also have PD cyclers, again in the gym, as shown on the right side, showing to you that we can provide these dialysis treatments very quickly. Now, we have novel algorithms that we have made, and these are geared towards the immunologic mechanism of leptospirosis. With acute kidney injury, we're not very bothered, because as long as they're treated with dialysis in a timely fashion, aggressive dialysis and control of acidosis, it is reversible. Usually, they only require 1 to 2 dialysis and the patient starts urinating, so that it's reversible in 1 to 2 weeks. However, once our patients have acute lung injury, especially pulmonary hemorrhage, it is invariably fatal despite maximum ventilation. So faced with this type of severity of organ dysfunction, we had to be more innovative and try to think of algorithms that will help control the disease as we see. So here we also have more concerns where to admit the patients. We had to identify a temporary ward. We showed you the gym. We have also financial support that we needed to look for. And when you're admitting already 50 patients or more with a single disease, you will need staff augmentation. And now we have a mechanism for this through the Department of Health. This is just to show to you that through the years, we have looked for areas to be provided with temporary wards, and that in 2019, we had to open that ward. And here is the conversion of the ward of the gym into our lepto ward. And because of this experience, in 2013, we came up with our own manual to institutionalize how we manage this disease, defining roles and responsibilities of each member of the crisis team, and so that it's a strategic way of managing this outbreak that occurs every year. I want to introduce you to some medical innovations. We changed our lepto protocol, where a standard protocol is just hydration, supportive treatment, and antibiotics, and dialysis if the patient needs it. We found that our mortality was very high, 26 to 28%. So we started in 2011 with a course of hydrocortisone. And however, we were not satisfied with that. There was still mortality that we wanted to control. So then we introduced use of methylprednisolone with cyclophosphamide. And in this paper in 2014, we explained, or we found that giving up pulse methylpred with cyclophosphamide was able to reduce our mortality from 26% to 12% versus patients on hydrocortisone alone. So we were able to reduce that mortality. We weren't happy. We were trying to look at, we reviewed that experience again using methylpred and IV cyclophosphamide, as shown here in 2018. And here we report that lepto with renal failure, we looked at it from January 2014 to 2016. They were treated with our pulse treatment. We had 194 patients, but 25% of patients died. We tried to look, why are these patients dying? And we found that 16% they were dying because of pulmonary hemorrhage, some with multi-organ failure and hospital-acquired pneumonia. So we tried to control that. What can we do with this pulmonary hemorrhage? We looked at significant predictors of mortality. We found low platelet count, prolonged prothrombin time, and presence of parenchymal infiltrates on X-ray. And based on this, these were the patients that are very severe, and therefore we give them very aggressive management. Let's look at the inflammatory mechanisms in sepsis, which I know all of you are very familiar with. I put here in infection a picture of our leptospira, and you can see that the end result is an increase in cytokines and the cytokine storm that is causing all the inflammation and continuous tissue organ damage. So we said this inflammation needs to be controlled. Dr. Obet Tanchanko showed you a very nice picture of the cytokine storm in sepsis. And it shows here on the left-hand side that here we have the pro-inflammatory arm in red, and blue is the anti-inflammatory arm. Sometimes, however, when you're here in this side, the B part of this diagram, that there's so much pro-inflammation, and that might be detrimental already to the patient. So if we catch the patient here, we see that there is continuing pulmonary hemorrhage, severe liver dysfunction that is occurring. And this is when we say that there might be a role for removal of those cytokines that are producing all that damage. And here is where we introduce hemoperfusion that is able to remove cytokines through this resin sorbent. It will be able to remove IL-6, TNF-alpha, and CRP. And therefore, by the removal of these cytokines from circulation, these cytokines are known to cause cardiovascular collapse, hypotension that doesn't improve despite our inotropes, and control of acidosis with dialysis. So here we find that there is a way wherein we can intervene through hemoperfusion to remove these cytokines. Another medical innovation is the use of extracorporeal membrane oxygenation, or ECMO. This is a process where blood goes out of the body here through the femoral cannula, and it goes through an oxygenator where oxygen is pumped in and CO2 is removed, and this oxygenated blood is returned back to the patient. This can last from 7 to 30 days, maybe even more, and it gives time for the lungs to heal. Similar to dialysis, wherein we're able to correct the azotemia and acidosis by an extracorporeal therapy, that is dialysis, while we give the kidneys time to heal. ECMO is a process that gives the lungs time to heal. And we were able to do this successfully last year. We had our first case of ECMO plus hemoperfusion in a patient with very severe leptospirosis and pulmonary hemorrhage, and we were able to get him off both dialysis and ECMO and ventilation, and this patient went home smiling and is now back to work. Since then, we've had 20 patients wherein we've done these 2 treatments on severe lepto with respiratory failure. Mean age was 33, males more predominant. CREA mean was 7.4 at baseline. Look at the SOFA scores, very elevated at 15. HSCRP and procalcitonin so increased, showing to us the marked inflammation that is happening in these patients. Unfortunately, we are unable to measure IL-6, TNF-alpha, and the other cytokines, so we are looking for another inflammatory marker to gauge whether these our treatments are effective in removing cytokines, and what we've done is to use HSCRP and procalcitonin. And here I show to you that the SOFA scores declined. Our serial procalcitonin also has a nice decline. HSCRP will decline, but it may increase again with further inflammation. And here I want to show you that the mean inotropic requirements decreased after hemoperfusion, shown here at baseline at the doses of our inotropes. We have here green dobutamine, we have dopamine in blue, and we have norepinephrine in the middle. And you can see that after the first hemoperfusion, they have declined. After the second, 2 are already off. And at the third hemoperfusion, it's already, all our inotropes are off. We do hemoperfusion daily for 3 days. So hemoperfusion and ECMO in these 20 patients resulted in 14 out of 20 who survived the illness, and patients who survived had complete recovery of lung and kidney function. And I show here to you the x-rays that are typical of these patients who will require this disease. These patients are on mechanical ventilation with PEEP with 100% FiO2, but still with very low PO2s, very low PF ratios. And you can see that given time in this group of patients, the lungs are capable of healing and the kidneys will heal as well. So we have very good experience, and we are studying this more completely. So with ECMO plus hemoperfusion, which we started, our mortality from lung hemorrhage has been reduced from 100% mortality once the patients had lung hemorrhage to 25% mortality for these devastating manifestations. So in 2020, what's next? We are now developing, or we have developed a scoring index to predict mortality in these very severe patients. It's very important for us to be able to identify who needs very careful monitoring, who needs an intensive monitoring, who will need very aggressive management. And in this review, in the last 5 years of 751 patients with this disease, we had a mortality already down to 17%. They were again mostly males, aged 37.5 years, and 82% of our patients required dialysis. We developed what we call the DIVA scoring index, and a score of more than 2 was found to result in 11 times risk of death. So if the patient has diabetes, icteria, requires ventilation, and patient is anuric, you can see here the odds ratio of death. Look that if the patient is already on mechanical ventilation, the odds ratio was already very high at 34. So by identifying patients who may have very severe disease, we know who we are watching out for. The rapid deterioration is very marked, as in you can be talking to the patient who's just on the face mask with oxygen support, he's feeling okay, he can lie down with just 2 pillows, and at night he is dead from pulmonary hemorrhage. So by using these scoring systems, we may be able to identify these patients who can rapidly deteriorate. Another thing we have done is develop a scoring index to predict pulmonary complications in lepto with renal involvement. And this is a study done in 2018. We had 380 patients, mean age of 38 years. Our overall mortality was 14%. However, a quarter of them will develop lung complications. And among those who will develop lung complications, half of them will be dead. So again, the need for how do we identify these patients who will have a 50% chance of dying? And we have developed this scoring index composed of dyspnea, hemoptysis, diabetes, need for dialysis, thrombocytopenia, and anuria. And by identifying these patients at highest risk of death will warrant intensive monitoring and early aggressive management. So with all of this experience, we have, after several years, come up with the second edition of our handbook. We can now help institutions by giving them a policy on how to augment their staff in cases of these outbreaks. We have now included indications for ECMO and hemoperfusion, and even guidelines on blood component transfusion. So conclusions: leptospirosis is a devastating disease that recurrently appears during the rainy season. Severe lepto with acute renal and lung failure and liver dysfunction leads to high mortality. Immunosuppression, in addition to standard of care, has led to a reduction in mortality in this high-risk population. And although the kidneys recover quickly, the role of lepto as a contributing factor to the development of CKD needs further study. Innovative treatments like hemoperfusion are used to halt the cytokine storm and support cardiovascular stability, and ECMO is used to provide adequate respiration while the lungs recover from pulmonary hemorrhage. Simple scoring systems have been developed to predict patients at the highest risk of death and to identify those who may develop severe pulmonary complications. So we've come far, but there's still more to do. We want to see if we can still bring down that mortality further. And with that, I'd like to thank you for your kind attention.
Thank you, Dr. Romina Dangilan, for a wonderful presentation. She was not on, Dr. Dangilan was able not only to present the risk factor, the clinical manifestation, the treatment in leptospirosis, but she had added a protocol to reduce mortality. In the books, Ones with Pulmonary Hemorrhage, most of the leptospirosis infection would have 100% mortality, and I would like to congratulate Dr. Dangilan for having a protocol to reduce, imagine, from 100% to a 25% mortality. And she wants a better prognosis, so there will be, we will hear from her again for another protocol in reducing the mortality in leptospirosis. And again, I would like to congratulate both Dr. Roberto Tanchanco and Dr. Romina Dangilan for giving us a lecture in a short duration. It is very informative, and we learned a lot. So for the question, for the first question, it will be addressed to Dr. Tanchanco. Have you have an experience using ECMO or in treating COVID-19?
There is one patient where the ECMO procedure was used. So the modality was a VV ECMO, so it's mainly for pulmonary support. It was also described by Dr. Danilan in her talk. And this patient, this is a COVID-19, and then required the ECMO. The indications were there, was able to decannulate. But at this point, the story is still unfolding. But ECMO was used and stopped. But the course is still that the patient is still admitted.
Wow. Thank you. Can we also ask Dr. Dangilan if she has experience with COVID-19 and ECMO, because I think NPI has also a lot of numbers with COVID.
Yes, we have a lot
question.
of patients with COVID, 209 patients with COVID admitted, many of them, majority on dialysis. However, we did not put them on ECMO because we are not a COVID hospital. So our ICU is not retrofitted for infectious disease such as this. So unfortunately, we have no experience on ECMO in COVID.
Thank you for that answer. Again, to Dr. Dangilan, it's the start of the rainy season, and with the pandemic also occurring, how can we differentiate leptospirosis and COVID-19 infection from each other? Can we differentiate them?
This is a very important question, and it's a challenge. And what's very important is our laboratory testing. So we do LAT to do IgM and IgG right away. And once we have a positive IgM, then we treat that patient as lepto. It's very interesting that you asked that, because we just recently discharged our first patient with both leptospirosis and COVID. And happily, this patient presented mainly with the leptospirosis part. And the lungs had some infiltrates in the beginning, and then it disappeared. The patient needed dialysis, and we didn't have to treat the patient specifically for COVID. And COVID didn't seem to be a very important manifestation. So the COVID was asymptomatic, and it was mainly leptospirosis. So the tests become very important. So all our patients in the ER with infiltrates on X-ray, we think that they might be pneumonia. So all of them will get a swab for COVID as well. So far, since January, we've admitted 21 patients with lepto. One or two come every week. Like now, there's somebody in the ER, again with severe disease. So it's really a heightened awareness of lepto in the COVID pandemic.
Thank you. First time I heard that there is a COVID-19 infection and leptospirosis. So for Dr. Obet, can dialysis patient recover from COVID-19 infection if they will have the infection?
Oh yes, definitely they can. We just know that the mortality rate and the severe manifestations tend to occur in more of those patients, but definitely they can recover.
Can you cite the difference in COVID-19 infection? You've stated hemodialysis and hemoperfusion. What's the difference between hemoperfusion and hemodialysis?
Oh, so the hemodialysis is really more for the removal of the toxins that accumulate because of kidney failure. So since we're using more of the urea kinetic modeling as our basis, we look at the removal of substances that are about the same size as urea, so the smaller substances. So that's hemodialysis. When you do hemoperfusion, it's not actually based on the removal of these small solutes, but your target is really the larger solutes that would not fit through the pores of the usual dialyzer membranes. So hemoperfusion works on the basis of adsorption. So adsorption, the image I have of adsorption is the mouse trap. So the mouse trap, the sticky pad. So when the mouse passes over it and then it sticks to it, and then you remove the pad itself, and the mouse is along with it. It's a very large substance, so to speak. That's the sort of way that hemoperfusion works. So the target substances that you want to remove are different. So when you talk about cytokine storm, the cytokines are molecules that are very large that would not be removed by the usual hemodialysis process. So when we talk about hemoperfusion in COVID, it might actually be used in some instances where you don't need dialysis, but you want to use the cytokine removal. So it's hemoperfusion without hemodialysis. We haven't done that in our center, but it's one of those treatment modalities out there that presents itself.
Thank you.
So I think I can share with that because we have a lot of COVID patients on dialysis, and our protocol is to do hemoperfusion for certain criteria, 12 hours for 2 doses, and then daily for 2 more days. So a total of 4 treatments with hemoperfusion. And the patients, if they're also on dialysis, then we can do it in series. In other words, the blood during the same treatment, the blood will go first through the hemoperfusion cartridge where you have adsorption of all these cytokines, and then the blood will then go into the dialyzer, and then removal of creatinine, etc. And you can do it together. And then in that case wherein the patient does not need dialysis on that day, you can do hemoperfusion again just using the hemodialysis machine.
Thank you for that, for sharing your experience. Again, for COVID-19, for Dr. Tanchanco, do you routinely do RT-PCR COVID tests for your HD patients who are with or without any presentation of respiratory symptoms prior to the dialysis, and what is the rationale behind it?
Actually, we do not, and I don't think it's rational. Um, RT-PCR, even in those that are positive, we know that the false negative rate is about 1/3. And if you do it in an asymptomatic patient, then I suppose the negative rate would be even higher. So on that basis, I don't think it'll pick up what you want it to pick up. From another perspective, we also consider the cost of this RT-PCR. It would be covered, I think, once by DOH. Um, but if you have it done on your own, I think the cost of an RT-PCR would be like the cost of maybe 2 or 3 dialysis sessions. So the rationale is not solid, and the cost perspectives even makes it less palatable as an option to implement. Jose, did you freeze or?
Thank you.
Yes.
Ah,
Okay.
Sorry, naglag yung
Yeah.
internet.
Yeah.
For Dr. Dangilan, what is the dose of cyclosteroids combination for severe sepsis? I think it's for the leptospirosis.
Yeah, so we give methylprednisolone 250 milligrams IV once a day for 3 days, and we give cyclophosphamide 1 gram IV as a single dose. Before, we used to give methylpred at 500 milligrams a day, but we were getting hospital-acquired pneumonia. So together with our infectious and pulmonary colleagues, we decided late last year to reduce it to 250 milligrams per dose for the methylprednisolone.
Thank you. Uh, for Dr. Dangilan, you mentioned that leptospirosis in asymptomatic patients could develop chronic kidney disease if not treated. But once you were able to catch a patient with leptospirosis, even though in asymptomatic case, how do we manage those patients to prevent renal complications?
Usually, you would treat them if they come into you with clinical signs and symptoms like fever, conjunctival suffusion, muscle aches. Uh, so you would give that patient a course of doxycycline, or if mild, and if severe, the patient would be given IV antibiotics. Uh, if the patient was asymptomatic, then but the patient had exposure to floods, wading in floods, swimming in floods, or works in an area, was bitten by rats, that kind of exposure, then we would advise giving that patient prophylaxis. So he would need to have doxycycline 200 milligrams a day as a single dose, or if high risk means actually bitten with open skin wounds, no, which would assume the leptospira or the water was able to penetrate the skin, then you would give the doxycycline for about 5 days. So you want to be very aware of the possibility of the disease, so that with exposure you could treat it, and so that you can prevent the chronic infection. It's something that we need to look at in our farmers, because if there's high incidence of lepto occurring there, or if that's a high incidence of CKD unidentified as to the exact etiology, maybe this is something that we need to look into, and that we need to do antibody measurements for these patients to determine if they do have leptospira in the body, or very high titers of the antibody, and maybe these patients that need to be treated. So this is a very new realm, no, that we're seeing.
Thank you. Probably this will be our last question. It's already 11:30. So for the two speakers, you said that leptospirosis patients have been present. Sorry. Since cytokine storm is both prominent in leptospirosis and COVID-19, is there a triage guidelines who will be managed first, the COVID-19 severe or leptospirosis severe? And is there a possible pulmonary hemorrhage in COVID-19? Thank you. Who?
Obet first.
Perhaps I was going to say Dr. Penny first because they have the direct experience. But just a second question about the pulmonary hemorrhage. No, that's not the scene. It's more of the ARDS, and if anything, there's increased clotting also that we see in the pulmonary system in COVID-19. The other part, perhaps I can defer to Dr. Danilan.
So, as you stated, the two diseases can present in a similar way. And we need to determine which of those diseases are more predominant in the clinical manifestations of the disease. Let's assume both COVID swab was positive and lepto IgM was also positive. So then we're left in a quandary. The inflammatory markers that we see in COVID are very marked. D-dimer so high, ferritins also skyrocketing, which we don't usually see in our lepto patients. Also, it's been shown that mechanical ventilation doesn't seem to be the right treatment for COVID, and that high flow nasal oxygen seems to be what they need. In our patients, if I felt or if the team felt that the COVID was the more predominating disease, then there's not a lot of pulmonary hemorrhage as shown, as stated by Obet. It's mostly like a thrombotic type of disease. We will put the patient maybe on high flow nasal, maybe do hemoperfusion, give tocilizumab, and see if the patient would respond. And they do. We've had patients with severe disease, x-ray so bad, already all white, but still the PF ratios seem to be good. Our pulmonaries were not happy to intubate these patients. They said, no, patients are stable, intubation is not needed. And with high flow nasal and with our hemoperfusion, tocilizumab, and other treatments, now giving of dexamethasone and giving of other treatments, the patients respond. In that case, it seems to be more like a COVID manifestation, because for our lepto patients, if the lungs were all white, that patient would have already pulmonary hemorrhage. We would see already hemoptysis and his ET tube filled with blood. So I feel that COVID is more thrombotic and our leptospirosis is more of pulmonary hemorrhage. But the treatments might be similar. Now we know we don't really want to intubate the COVID patient. But with pulmonary hemorrhage that will block all the alveoli and the bronchi, we probably need to do mechanical ventilation to be able to suction off all that blood. So it's a very tricky problem. It's very challenging. But I think with the experience that we have, we would be able to manage that patient, I feel.
Thank you. So there are a lot of more questions, so I would like to apologize to those who asked the question. Probably we will answer them either by writing to them or through email. During this webinar, I think there are more questions than the real live conferences, but I need to cut this one. So I would like again to congratulate Dr. Robert Tanchanco and Dr. Romina Dangilan. We were very honored that you were the speakers. We learned a lot. And again, congratulations to the PCP and to everyone. Good morning. Thank you.
Good morning. Thank you.
Thank you.
Okay.
Hey, look at the next one. Immunity.
So we would like to invite everyone to the next webinar, which is going to be next Monday, July 13 at the same time, 10 a.m. So please tune in to your Facebook Live or log in through Zoom. So the title would be Immunity and Cytokine Storm in COVID-19. Thank you. Have a nice day, everyone.